My name is Dr. Lynn Raymond, and I'm one of the co-directors of the Javad Moavagian Center for Brain Health at UBC. And I'm so pleased to see all of you tonight for what promises to be an inspiring and thought-provoking evening. Before we begin, I'd like to acknowledge that we're gathered today on the traditional, ancestral, and unceded lands of the Musqueam, Tsleil-Waututh, and Squamish nations. And we're grateful to be living and working here as we strive to improve brain health for all communities, including Indigenous peoples. So I'd like also to thank our partners at UBC's Office of Community Engagement and UBC Robson Square for co-hosting this event. This is the first 3 events that we'll be co-hosting together for this, what we call academic year. We have 2 more in early 2026. At the Javad Moavagian Center for Brain Health, our mission is to advance brain health and well-being across the lifespan through research, education, and clinical care. And what makes our center unique is that we have, under one roof, we bring scientific discovery in wet labs up on the top floors with clinical expertise in our clinics on the first 2 floors. And our community includes more than 150 scientists and some clinicians that include experts in fields of neurology, psychiatry, rehabilitation, and radiology. The center is the home for 6 clinics from ALS, Alzheimer's, Parkinson's, Huntington's, to mood disorders and MS. So together, we're really working to understand the molecular mechanisms of brain disorders in order to improve care in the clinic and support people affected by these disorders. Our ultimate aim is to translate discoveries from our labs into effective therapies in the clinic. So tonight's program is really what our center is about. It's right central to our mission. It connects science and wellness and shows how research can help us all live healthier, more resilient lives. And you'll hear that term a lot, resilient. I'm sure most of you know what I'm talking about. But we're all aging, and some do it more gracefully than others. We'd love to understand why. Why are some kind of resistant to the aging process a bit more than others? So we brought together 3 of UBC's experts in brain health to explore how learning, exercise, diet, and lifestyle shape the brain, not just in theory, but in ways that each of us can apply in our daily lives. And I think that's what's brought the crowd out tonight. Am I right? Okay. So after the presentations, we'll have time for a Q&A. The presentation should take until 7:30. And we have half an hour for a panel discussion for all of your questions with these experts. So now I'd like to introduce our first speaker, Dr. Lara Boyd, who's a professor and distinguished university scholar at UBC. Dr. Boyd is both a neuroscientist and a physiotherapist. And she directs the Brain Behavior Lab, where she studies how behavior and brain health interact to shape learning and recovery after brain injury. She's published more than 200 papers, received over $25 million in research funding, and her TEDx talk, which is, quote, "After watching this, your brain will not be the same," unquote. Look for that. Has reached more than 40 million viewers worldwide. So please join me in welcoming Dr. Lara Boyd as she is here.
Thanks so much, Lynn, and thank you everybody for coming out tonight. So as Dr. Raymond said, I'm Dr. Lara Boyd. I'm both a neuroscientist and I'm a physiotherapist. And I feel like I need to start by explaining a little bit about how the heck I got here. Well, first of all, I touched it and they told me not to. Okay. Well, I don't have slides, so not to worry, you won't be distracted. Ignore that. So, I was not supposed to be a scientist. When I was growing up, I wanted to be an English professor. So my first love is Shakespeare, to be quite honest. Now, I hurt my knee really badly playing basketball in college, because oddly tall, so of course I had to play basketball. And that got me interested in recovery and rehabilitation. So I decided to change the plans. I'll become a physical therapist. Went to school, finished school, and in the course of my education, I became really interested in the brain, and I didn't know quite enough about it. So I became a stroke rehabilitation specialist. I thought, okay, this is a great way for me to learn about the brain. And it was absolutely terrible. I couldn't help my patients because I didn't understand how the brain worked. And it drove me completely crazy. And so I wound up quitting my job. And yes, my parents were highly alarmed. I had a house, a mortgage, I sold it, I went back to school, and I earned a doctorate in neuroscience. And it's been the most amazing journey I've been on ever since, because in that time, what we've learned about the brain and our just basic conception of the brain has changed magnificently. So just to set the stage, when I earned my master's degree, we thought that probably after childhood, the brain didn't change. And any change that did happen after childhood was really bad. So you were losing neurons, brain cells, because you got old, or you hurt your brain, and you had a stroke or a head injury or a disease, and your brain was degenerating. So that turns out to be totally untrue. And about the time I was a doctoral student, a series of experiments were published using animals showing that after they induced damage in the brain, you were seeing cortical reorganization. The brain was changing. And so that led to just a full reconceptualization of the field and of how we view both neurology and, important to me, rehabilitation after the brain is actually hurt. So why do I think this discovery is so exciting, and why am I here trying to convince you that it is? And I hope by the end of this you'll be very convinced. Well, so firstly, the first really exciting thing is that these brain changes are how we learn. So when our brain changes, it's changing because we've encoded something new, because we've learned a new behavior, we have a new skill, we have a new habit. Now, really exciting to me, and getting more exciting by the day, is that these processes are not limited by age. So, hallelujah. We're going to be able to learn our entire life. We're continually changing our brain. And really exciting is this is probably what supports recovery after the brain is damaged, such as a stroke. So I finally have a bit of an answer as to what I can do to help my patients get better after their brain is damaged. So I want to take a minute, if you will indulge me, and I want to explain to you what neuroplasticity looks like in the brain. So how does it do this amazing changing organ in our body? So if you think about the brain, or the way I think about it as this really beautiful, intricate forest. So our brain is made up of billions of brain cells. We call them neurons. And these look a little bit like trees to me. So they have these big, beautiful branches up top. Those branches come together, and they form into a long trunk, and then there's branches down at the bottom. You can think about it, the roots. And imagine how billions of these beautiful trees, which we call neurons, really closely align together in the brain. Now, what's really neat about these neurons is that they can communicate incredibly effectively with one another. But the way they do so is highly unique. So they don't actually touch one another. They're communicating by chemical signaling. So little packages of chemicals are passing from one to the other, and it creates this wave of change and excitability in the brain. Now, when we're learning something new, the concentration of those chemicals, called neurotransmitters, can change really, really quickly in the brain. And that's what we think supports a short-term memory. So it's a memory that's fragile. We might have for just a minute, but it's not necessarily permanent yet. As we do this over and over again, the structure of our brain will start to change. So what that looks like is these beautiful branches, we call them dendrites of the neurons, they can start to reorganize. We can have more and less of them. These connections where the chemicals pass, we can have more or less of them. And it takes time for these structural changes to take place. It also probably takes sleep, and this is why sleep is so important for both learning and brain health. But with time, and with practice, and with sleep, we slowly start to change the structure of our brain. And this is what supports a more permanent memory, a long-term memory, or learning. So we've all had this experience. You know what this feels like in your daily life. Have you ever tried to learn something? Let's say you're practicing it, and you think you've got it, and you come back the next day and you don't got it, it's gone, right? You might have been learning to play the piano, or this summer I decided I was going to learn to juggle. It's really hard. It's a lot harder than you think. And if you can juggle, I'm very jealous. But so I can practice, and I have my 2 balls going, right? And I think I've got it, and I come back the next day and balls are flying, and I'm terrible. So what's happening there is that short-term memory from my practice isn't converting into a long-term memory. So there's other ways that brain structure can change to support learning and memory. So we know that in areas of the brain that we use a lot more, we'll see that they're actually thicker. And we have these amazing machines called magnetic resonance imaging, where we can actually take pictures of the brain. We can see its function and structure changing. And so we can index these. And so we know, for example, people who read Braille, their finger representation is much larger than those of us who don't. Or, for all of us in the brain, we have a dominant hand, the hand we write with, we brush our teeth with, we use a fork with. That area of the brain that corresponds to that dominant hand is much bigger than the other side, which does a little bit less activity, maybe a little bit less intricate skill. So this is how brain structure is also changing to allow us to create memories and to learn. And then the last way is through our brain function. So our brain, different parts of the brain are doing different things. They're contributing in different ways. And these functional areas work together in these intricate networks to support our behavior. Now we know with learning that these networks will change. They'll change the shape of their activity. And what we can see is that, and most often as we learn something, our brain function can lessen. Our brains become more efficient at supporting that behavior. And sometimes when we get really good at things, certain brain regions can even turn off. So for example, if you're learning something new, you have to pay a lot of attention. I was writing this talk and I was really thinking hard about what I wanted to tell you tonight. So I was using the frontal part of my brain, which is important for attention. Then once you have the skill, you become pretty good at it, you can turn down or even turn off that attentional part of your brain. Maybe if you can turn it off, you can do 2 things at once. Maybe not as skilled as you think you're doing now, but you can still try, right? We all do this. And so this is how our brain function is also changing to support learning and memory. And so together, we're changing our chemistry, our structure, and our function, and those in concert are supporting how we learn. I'm going to come back to my stroke patients. So I hope I've convinced you that your brain is amazing, and that it can change in a lot of different ways, and that that change is supporting learning, and also supporting recovery of function. So, if I've convinced you of that, my next question would be, my stroke patients, I must have figured out how to make them get better, right? How to help them, because the brain is amazing, and we know all this about it. It turns out that it's not exactly that simple, that we're still really, really struggling to figure out how to help people with stroke recover. And a few problems are really challenging us. So one of the problems we confront is that the amount of practice, what we call the dose of practice, that it takes to change your brain is really high. We think it's tens of thousands of repetitions of movements, or tens of thousands of hours of practice or study to really become a master at something, right? And the problem we have when you think about a patient with stroke, if you think somebody needs tens of thousands of hours of repetition, our medical system is simply not set up to do that. To fix that would be cost prohibitive. We would all be bankrupt. We couldn't afford it. It would be incredibly time and labor intensive. So we're kind of stuck. We know it's a huge dose of practice that needs to happen, and we can't figure out quite how to give it. And I think about it this way. I think about if you have a really bad headache, and you take a baby aspirin, and you still have a headache, and you think, well, why do you still have a headache? I took a baby aspirin. That's a little bit how I conceptualize stroke rehab right now. We know we need to give more, and we're just not sure how to get there. So this is a problem that my lab at UBC thinks a lot about. And we've developed several different kinds of interventions that we've been trying to test to try to make the effectiveness of the rehab we can give even better, even more. And so the way we think about this is through using what we call adjunct interventions. So we have tools that allow us to actually change the excitability of the brain. And we can do this and then pair rehabilitation with it. We can put them together. So what are we thinking about? Well, one of the things we've tested quite a bit and are continuing to work on is the idea that we can actually use brain stimulation non-invasively to pre-excite certain parts of the brain, and then use that pre-excited brain, send that brain into rehabilitation, and see if we can amplify the effect by kind of preparing the brain to be better at learning. So we use tools called transcranial magnetic stimulation to do this. And so right now we're actually running clinical trials with people with acute stroke, looking at pairing brain stimulation, both with a motor intervention for movement recovery, but also with a cognitive training program to try to facilitate improvements in thinking and planning. We're trying to test to see if that might be one way to amplify recovery. Another way that we've looked at this is by pairing exercise with rehabilitation. Now, I'm not going to say too much about exercise because the world's expert in exercise is right there, and I don't want to say something silly. You'll hear more about it tonight. But in our work, we use a very specific kind of exercise. It's called high-intensity interval training. So people exercise really hard for a short bout of time. Now, exercise is like rocket fuel to your brain. When you do a short bout of exercise, the excitability of your brain increases an enormous amount. And then we leverage that by coming right in and having people practice something new right behind it. And we've shown that this is very effective. It can help people learn faster, and that's true for young people, older people, and people with stroke. And it also transfers to improve our ability to think. So we see these transfer effects to cognitive things that weren't even trained. And so that's a really lovely side benefit of our exercise work. And then lastly, we've been working really hard to gamify rehab. So we've developed a computer game. Years ago, we were sitting around in my lab, and I was musing out loud, what could we do that people would practice 10,000 times? And a student in my lab, a very young undergraduate student at UBC at the time, was like, well, game. If you developed a game that was really cool, they'd play it all the time. So we've been working on this for about 12 years now, and we have a game which we're testing right now. And the idea is that patients play this game. It's not meant to replace rehab, it's a supplement. And they're reaching out, and very importantly, they're catching asteroids. And they're saving that asteroid from hitting the earth and blowing us all up. And they throw it into an extractor where it's extracted for minerals. And this game actually is a way of getting stroke patients to make a lot of movements in a safe and cost-effective environment. They could even take this game home and practice it. So it's just another way we're trying to think about how can we amplify these effects that we know work and try to get more out of them. Now, one of the other problems that we've run into is that responses to every intervention are really variable. And so one big lesson we've learned is that there's really no recipe for learning. There's no one-size-fits-all approach that we can deliver to people. And so this has been really interesting to us. We see so much variability in patients and how they're responding to things. And this has led us to think very carefully about how we could get the right intervention to the right person and at the right time. And so this has led us to think a lot about what we call biomarkers. So a biomarker is just something we can measure that's going to tell us whether or not someone will respond. Biomarkers could be things like blood, they could be genetics, or in our instance, we use brain imaging data. And what we found is that there's not a single biomarker that's best for stroke prediction, but if we combine several biomarkers together into a combined score, that seems to be really helpful. And it's not really surprising that it would be a combination score that would be best, considering how complicated the brain is and how extra hard it is to help people recover after stroke. It seems appropriate then that we have a very complicated biomarker kind of combination that would work best here. But it's led us to think a lot about this idea that we need to start to consider how to personalize rehabilitation for people with stroke. So thinking about what's going to be the best for that individual at that time, and using data to help shape that. And that's really my vision for how I would like to see stroke recovery look by the time I get to end my career. But I think this idea of brain complexity in biomarkers, it raises a bigger question, and that is, I wonder how much of this we should be extending into our own daily lives. So that is, we're all unique learners, and each of us has an incredibly unique brain that's absolutely shaped by our past experience, our behavior, our motivation, maybe a past medical issue or challenge you've had. And so that brain is going to respond uniquely, and that's going to make each of us just as unique of a learner as the patients are that we work with in my lab. And so I wonder if this helps us understand, why we all learn so differently. So some of you probably are great at learning languages, and you speak 2, 3, 4, 5 languages. Some of us aren't. So what's different about those brains? What's causing you to be better at learning languages than certainly I am? And I also wonder a lot about this when I think about school. So we think about education. We kind of put our kids through this one-size-fits-all education model. We squeeze them through it. And some kids do great, but a lot of kids don't. And maybe that's another instance where we really need to start thinking about these individual variations in how we learn and how our brain changes when we learn. I hope I've convinced you that your brain is amazing. So my favorite thing to say, and I'm going to say it, when you leave this room tonight, your brain will not be the same as when you entered. And I think that's just amazing, and I hope that you do too. So thank you very much.
Hey, thank you so much, Lara, for that fascinating look at how learning changes our brains. Our next speaker is Dr. Silke Appel-Cresswell. She's Associate Professor of Neurology, the Mar-Meagle Professor for Research in Parkinson's, as well as the Director of the Pacific Parkinson's Research Center. Her research focuses on a holistic approach to brain health. She combines clinical expertise with an understanding of lifestyle and community wellness. She's also co-founder of the BC Brain Wellness Program. How many of you have heard of that or even participated? And so quite a few in the audience. Thanks for coming. And that program integrates exercise, nutrition, mindfulness, and art. All 4 of those things to support people living with brain disorders or people who just want to maintain brain health. So tonight, she's going to share her talk entitled Eat, Play, Love, Nutrition, and Other Healthy Habits for Our Brains. Dr. Appel-Cresswell.
And a very warm welcome to all of you. It's really amazing to see so many people here, so we're all interested in the same thing. And there we go, eat, play, love, and also sleep afterwards, as we've already heard. So I think we're witnessing a very profound shift in how we are approaching brain conditions and how we're approaching brain health. And this shift is one to a much more proactive approach, where we look at, and this is the example of Parkinson's disease, a much more patient or person-centered approach, an approach that is more individualized, that is fostering self-agency, and that also looks at things like spiritual well-being and a sense of meaning and purpose. There's a lovely flower there which shows a lot of those different components. One of the very big ones is exercise. Unfortunately, we have the world expert here, so won't say much about this tonight. Diet, which we'll talk about, but there are also mind-body approaches. There's meaningful engagement in the community and in life in general. There's social connection, mental health, of course, meaning and purpose, and then again, sleep, really important, sleep for our brain health. So let's start with eat, so nutrition, and because I'm a physician who is specialized in Parkinson's disease, I'll do this with the example of Parkinson's disease. So you are what you eat. This is somewhat seasonal comment here. That can go wrong, and there is potential for things to go wrong. The Lancet Nutrition Commission actually came to the conclusion that unhealthy diets pose a greater risk to morbidity and mortality than does unsafe sex and alcohol, drug, and tobacco use combined. That's a lot. It is difficult to study, and I think that is why we don't have quite as many studies as taking a particular drug, because that's much easier to organize as a study. There's a long history of, in this case, ultra-processed foods and how they came in the late 1900s into existence, and then there's Coca-Cola, there's Jello, then through the world wars there was of course a need to produce foods that were stable and that could be eaten in the field. TV dinners, and then if you now walk down a grocery aisle, you see a lot of those examples. If you go to a store that we probably all know near me, where, you know, after standing in a long line for the checkout, where everybody's completely exhausted, the kids are screaming, they just want food, you come to this particular sign up, and they took a picture of that, which really struck me as this is the worst of the Western diet. You know, we've got processed food, we've got fried food, we've got sugar drinks, we've got pastries and sweets in excess, and I've got a sweet tooth, but this is, you know, somewhat excessive. And we've got a lot of red meat. So, I wonder, and there is no study that I can show you to prove that, but I do wonder whether the high prevalence we have for Parkinson's disease in North America, and you can already see the colors orange and red there, it's pretty obvious, whether that has anything to do with the quality of our food as well. Because the countries around the Mediterranean and countries everywhere else who are living off a more plant-based, wholesome diet, they do much better. And it is no surprise, and I think most people in this room know, that a Mediterranean diet has many health benefits, many benefits for aging, and that is true, and there have been good studies for cardiovascular disease, so heart attacks, strokes, diabetes, metabolic health, overweight, obesity, cancers. And what these diets do is that they, at the same time, actually act on several mechanisms. So there are, for example, reductions in oxidative stress, there are reductions in inflammation, there is an improved DNA repair, there is improved insulin signaling, there are several of these cellular mechanisms that are happening that are working better. So instead of just putting the finger into one hole in the dike, of what happens when we're aging, it is just putting your fingers into many more holes in the dike. And interestingly enough, if you look at those mechanisms of action, and if you look at mechanisms of action of exercise, for example, there's a lot of overlap. So they act on numerous mechanisms and they act on them together. And when we then look at what goes wrong in things like Parkinson's disease, you see a list that includes those mechanisms of action. So it seems to be a good match, and it tackles the problem on numerous levels. So you have more fingers in the dike, rather than trying to just use one mechanism and hope that all the other holes stop pouring miraculously. When I summarize the evidence that we have in Parkinson's disease, and this is mostly from observational studies, so most of that are big cohort studies and looking at populations rather than randomized controlled trial interventions, which would be the gold standard for evidence. So when we look at the evidence we have, there is evidence that is very much synergistic between all these different studies, saying the risk of Parkinson's disease goes down, the risk of what we call premotor Parkinsonism goes down with a healthy diet, the age of Parkinson's onset goes up. That's work that was done in our lab. There can be a difference of up to 17 years for the women who are eating a poorer or a much healthier diet. The rate of progression can go down, and this is now the ultimate outcome. Mortality rates go down with a diet that is based on mostly plants with a lot of leafy greens, vegetables, fruits, nuts, seeds, legumes, whole grains, olive oil, fish as well, and is short of all the things that we looked at before. And the one study that I'd like to highlight here particularly is a study that is very large, which has over 170,000 people in it. It was run from the 1980s for over 30 years, and the participants in this study were health professionals, filled in questionnaires on exercise and on diet every 2 to 4 years. Over time, nobody at the beginning had Parkinson's disease, but over time, over 1,200 people developed Parkinson's disease. And because it was such a long study, over 900 people died who had Parkinson's disease. So that allowed them to look at who was more likely to pass away versus who was more likely to survive. And to make a long story short, it turned out that in those people who developed Parkinson's disease, the people who were eating the healthiest diet, so who were in the top quartile for healthiest diet, were 30% less likely to die. No, sorry, 40% less likely to die. The people who were in the top quartile for exercise were 50% less likely to die, all compared to the bottom quartile. And the people who were both eating healthily and exercising, so were in the top quarter for both diet and exercise, they were 65% less likely to die. Now, this might be reverse causation. Maybe the people who are doing better anyway were also more likely to exercise and eat better. But there's not much we can lose because both of these things also have all these other health benefits and they have hardly any side effects. So we have no medication that gets anywhere close to that. If we had one, this would be a complete blockbuster. So, which brings me to the role of movement, exercise, dance, mind-body practices, art being creative, so the play part. And again, I'm not going to actually say much about this because we have the expert here, particularly for exercise, but just to say, being engaged in life and being active, as we already just heard, so that was the perfect setup, is really important. But it brings me to the role of social connection, the love part of this talk. And it brings me to loneliness, which is really an epidemic we have right now. In particularly people who are older, but unfortunately also in our young people, in the 18 to 24-year-olds, 18 to 30-year-olds. So what is loneliness? Loneliness is distress due to a perceived discrepancy between the desired social interactions and the actual existing social interactions. It comes with feeling of being left out, of being unloved, of just being much more isolated. And that is associated, loneliness is associated with an increased risk of anxiety and depression, with an increased risk of heart disease, with an increased risk of dementia, with an increased risk of stroke, and with an increased risk of Parkinson's disease. And we're talking big increased risks. It is associated with poor immune system function. It is associated with increased inflammation, similar to not exercising. It is associated with an increased risk of premature death. In the Harvard aging study, which ran for over, or still running for over 80 years, this was comparable to smoking. It is also associated with a reduced performance at work, reduced performance at school, and I think quite possibly also with the risk of societal polarization, which we obviously see currently greatly happening. The brain itself feels an alarm. Loneliness and our reaction to it is really an emergency signal. And it is so important for us as humans who are a very social species. We are all here because we are very social, because we are successful as a species, because we work together. And if we feel we're left out in the night, in the cold, on our own, this is a question of survival. So the intense feelings of loneliness, the discomfort that comes with that, is really there to make us act on this and to seek the company of other people. When we have higher loneliness, there's less wisdom, there's less compassion as well. And we can also see structural and functional changes in these brain regions. And again, you already talked about this. So we can see that in the brain. Loneliness in people with Parkinson's disease is actually fairly common. About a quarter to half of people would report feelings of loneliness. But in reverse, loneliness before somebody has Parkinson's disease also is associated with an increased risk of Parkinson's disease in the decade afterwards. Fortunately, something called social prescriptions can be helpful for that. And social prescriptions are things like a prescription for group exercise classes, for art-based therapy, nutritional and cooking classes, etc. And so, to summarize this first part, who here knows, show of hands, that exercise, healthy eating, being socially, cognitively, creatively engaged is important for our brain health? Everybody, okay, we succeeded. Who here does this, like brushing teeth, on a regular and ongoing basis? It's still quite a few people, so we're preaching to the choir. You'll see that I didn't have my hand up either because, I would love to do all of this, but I do still fall short. And so do many other people. And so that brings us to the question, how do we bring this knowledge that we should do all these people to actual sustained action? And we were wondering about this in the clinic as well, where of course in my particular case I see people living with Parkinson's disease, and then you add all these symptoms of Parkinson's disease and you add the worsening symptoms, secondary health conditions that come from a sedentary lifestyle, you add depression, anxiety, apathy, you add physical disability, you add financial hardships, you add social isolation and hopelessness, and then the circle just continues. So we decided in 2019 to found the BC Brain Wellness Program, which is an outreach program for the Java Moorfardian Center for Brain Health. It is also an extension of the clinic. That was October 2019. And as pretty much everybody remembers, in March 2020, mid-March 2020, we hit another roadblock. But fortunately, it was so clear from our, at that point, in-person program that we really needed to continue, that within 2 weeks, we were online, and this is Sally Stelling, our co-director and lead for exercise and education. She said, we just have to continue, and we were on Zoom within 2 weeks, and then went on to do a lot of online classes, which was a blessing in disguise, because from the 70 people in person in the beginning, we grew to well over 2,500 people, and I'm using my scarf, and we have in the meantime delivered way over 4,000 hours of program delivery. Just last year in 2024, we had around 32,000 instances of people checking in for a program. And important to really do these things together, because it's the combination of these things that are so much more powerful than just one of them on their own. So the program, here's an overview, has the program delivery side with exercise, dance, yoga. We've got anything from, the highest level is the high intensity interval training to chair yoga. We have a care partner program. We have creative and expressive classes with things like improv theater and music and visual arts. We've got specific projects and initiatives like life stories. We have the educational part where we have a lot of students who are coming through our program and who are participating in seeing our participants, and these come from the School of Kinesiology, Physiotherapy, Dietetics, Neuropsychology. Students are also involved as volunteers. We have in any given semester about 50 volunteers, students with us. And then we do research both for the program implementation and specific questions, including, for example, combined intervention, the Impact 360 studies, where we combine exercise, diet, and mindfulness. And today's, for example, a mindfulness component right after people do exercise in the study. For the very reason that was very much inspired actually by Dr. Boyd's work. So it's inclusive. We have both online as well as in-person classes. And for anybody who doesn't know, it is self-referral. So you can just go on the website and sign up. There's going to be a one-on-one assessment for the exercise classes with a recommendation which class would be a good fit. Because it's group-based, it is very much creating community. And that was also what came out in a word cloud. We asked our participants to give us 6 words that they associated with brain wellness. And the word that came out the biggest was community. That regardless of what people did, this is really what we're creating, and that really speaks to the meaning of community. It is also a completely donor-funded program, supported by many people in that community. And so with that, let's move and play. Let's enjoy wholesome food together, and then get some good sleep. That's it.
short, showing how good nutrition and daily habits can nourish both body and mind. So our final speaker this evening is Dr. Teresa Liu-Ambrose, another physiotherapist like Lara Boyd, and a Tier 1 chair, so that's the highest level, an award through the federal government, quite competitive. It's a Canada Research Chair in Healthy Aging, and Director of the Aging, Mobility, and Cognitive Health Lab at UBC. She's also one of the co-directors of the Center for Aging Smart. She can tell you what the SMART acronym means. The director of Vancouver General Hospital's Falls Prevention Clinic, and leads the Canadian Longitudinal Study on Aging data site that's at UBC. This is a nationwide study. Her work has transformed how we understand the relationship between exercise, cognition, and mobility, and has directly shaped clinical practice and international guidelines that promote healthy aging. So her talk tonight, The Brain-Body Connection, Exercise as a Catalyst for Cognitive and Physical Resilience, explores how movement is important for both brain and body. Please join me in welcoming Dr. Teresa Liu-Ambrose.
Thanks, everybody, and thank you for that very kind introduction. It's really a pleasure for me to be here today. I can't believe how many of you are here today. Thank you so much for being here. So what I thought I would do for the next 15 minutes is really to highlight how regular physical activity can strengthen both your body and your mind. I'm sure you know about this, and what I hope to do today is really kind of impress you with some of the latest evidence, and in doing so, keeping you resilient. So to start, I just want to talk about what is resilience. So you heard that term, and in many ways, generally resilience refers to our ability to adapt, to recover, and to maintain function despite stress, disease, or age-related changes. And there's different types of resilience. There's physical resilience, your capacity to recover, let's say, after injury or after surgery. There's cognitive resilience, which is your capacity to maintain cognitive function despite aging or potentially due to disease. And then there's also psychosocial resilience, which is our ability to cope with both emotional and social stressors. And when I think of resilience, I do think about my dad. So here's a photo of some of my favorite people. It's my dad, Jamie, my oldest, and my mom. So Jamie, actually, fun fact, just got married. He's only 26, so that was a bit of a stressor for me. But all good, wedding went off perfectly. But my dad, he is now 92 and my mom is 89. My dad is not without health conditions. So in 2012, so when he was 79 years old, we were having lunch, and also he couldn't remember our home number, the same number we had since about 1980. Blanked out, could not figure it out whatsoever, asked him a few other questions, and he completely just could not remember the most basic information. So of course, quickly after lunch, we took him to the emergency to figure out what is happening. And it turned out he didn't have a stroke, but he certainly did have some event, likely a transient ischemic attack. And so of course, with due diligence, he had lots of investigations, including neuroimaging. And on neuroimaging, what showed is that he actually had a lot of what we call cerebral small vessel disease. So this is kind of disease of your small vessels that feed your brain. And instead of having a stroke, he has all these little parts of his brain that basically is diseased. So he has that. He also has type 2 diabetes. He also has high blood pressure. And these are all conditions that we know are bad for the brain. So that's in 2012. And in present day, he still is pretty good. So he still files his own taxes. I don't know about you, but I'm intimidated by my own taxes. He still manages his rental. We do help him, but he still manages. And he still manages his own finances just fine. He still lectures me every day. So he really is an example of being resilient, such that, he certainly has risk factors. He has frank disease in his brain, but yet he's able to maintain his cognitive abilities. Similarly, he has scoliosis. He has some degeneration in his spine, but he's still quite mobile. So at Jamie's wedding, one of the biggest sort of like shockers to everybody is the fact that he's still mobile without a cane or without any sort of walking aid. So he, to me, is a living example of someone who is resilient. And so what contributes to our resilience? So genetics certainly does, but we're not dictated by our genes. So our resilience is also shaped by how we live and the environment that we immerse ourselves in every day. And some of these factors we already heard about, but some of the key factors we know that contribute to resilience is education, how often you expose yourself to new experiences and thereby learning, your social network. So social network is really critical for healthy aging and also does contribute to your resilience, how you handle stress on a daily basis, your nutrition, sleep. So these are all things you've heard, and of course, physical activity. And what I like to do today is really, again, highlight the role of physical activity in building both your brain health and your physical health so that you remain resilient as you age. Now, when it comes to the evidence for physical activity in promoting your brain health, the evidence is sufficient such that international organizations such as the World Health Organization, as well as the Global Council on Brain Health, has publicly recommended physical activity as a way of promoting brain health. And the evidence that led to these public recommendations really stem from studies where we observe people over time, so like the Canadian longitudinal study on aging, as well as randomized controlled trials where we specifically intervene and deliver exercise to individuals, and we basically measure people's cognitive abilities and potentially their brains through neuroimaging before and after. And across the cohort studies, it's been repeatedly shown that the higher physical activity someone reports that they engage in, whether through questionnaires or through direct measurements such as wearables, so like your Apple Watch, although we use devices that are a bit more accurate for research, it's been shown that higher levels of physical activity is related to reduced dementia risk. However, I just want to emphasize the dose is is very manageable, such that running a marathon is not necessary. If anything, one of my colleagues and close friend, Kirk Erickson, showed that among individuals who reported walking just over 1 kilometer per day had reduced risk of both cognitive impairment and preserved their brain volumes across 15 years afterwards of looking at individuals' physical activity. And when you look at 1 kilometer per day, does anybody want to share how many laps around is that in a standard track? Or a little bit over estimate. So once around, yeah? 2.5. 2.5. Exactly. So 2.5 around the standard track. And for many of us, the reasons we don't get our physical activity in is because we don't have time. So I also just want to highlight, assuming a gait speed of 1.24, that's not super fast, nor super slow, sort of the average gait speed of an older adult, that's about a 14-minute walk. So what we're understanding is that the dose is actually pretty manageable. Another study actually shows 7,000 steps per day, which roughly maps up to 4 to 5 kilometers, depending how tall you are, can actually reduce your dementia risk by 38%. So it's pretty impressive, isn't it? And again, generally manageable. Now, one of the limitations of these evidence, as Dr. Cresswell mentioned, is that they could be limited by what we call reverse causation, such that people who tend to report higher physical activity or are engaged in regular physical activity, there's something about them that they're more robust, and therefore they have reduced risk of developing cognitive impairment with aging. And thus, we still need evidence from what we call randomized controlled trials or intervention studies, where we again purposely deliver the intervention and we map how people are before and after. And this is the type of study that I tend to specialize here at UBC. And what these studies show is quite impressively is that when it comes to exercise, it's not just about actually potentially improving your cognitive function after you intervene, but that you can also change the brain. So again, Kirk, again, a close colleague of mine, showed that among otherwise cognitively healthy older adults, after engaging in a 3 times per week of walking program for 12 months, you can actually improve your memory. So not just maintain it, but improve it as compared when you first started the program, and also increase the size of your hippocampus. So the hippocampus is a specific structure in your temporal lobe. So if you take your finger and just kind of jab it into your ear, you're kind of over the temporal lobe, and that houses your hippocampus. The hippocampus is your memory center. It's what allows you to remember things. With normal aging, it actually starts reducing in size by the time you're 50. So 50 years and onwards, it can actually reduce in size by approximately 1% per year. What Kirk showed is that after training for 12 months with a basic walking program, it increased by 2%. So it's like literally reversing your brain age by upwards of 2 years. Here at UBC, we tend to specialize in looking at how different types of exercise programming promote your brain health. So when we think about exercise and brain health, I'm sure many of you think about, well, you know, it's beneficial because it increases blood flow to the brain, and it certainly does. And your brain is highly metabolic and does really need the blood. But it doesn't mean other types of exercise isn't beneficial for your brain. You have to remember or know this, that the way exercise promotes brain health is really almost like multi-pathway. It probably targets every single system, okay? But one of the ways we know that exercise promotes brain health is through the release of neurotrophic factors. So these factors actually promote neuronal growth, survival, and also helps grow new connections. So you heard about the term neurotransmitters. Well, when you exercise, you actually release them. And so there's no reason why other types of exercise training could not be beneficial for your brain as well. And so here at UBC, what we showed is that resistance training or strength training also has beneficials for both your cognitive function as well as your brain health. And in particular, we also show that it can actually mitigate existing disease within the brain. Remember how I talked about my dad's brain scan showed that he had all this sort of disease in his small blood vessels, and as a result, there's pockets of his brain that really has experienced cell death. Well, those small vessels, when they're diseased, they tend to just progress over time. And the unfortunate news is that when we look at population studies, by the time we're 65, about 90% of us have this cerebral small vessel disease. And what we have shown is that through exercise, specifically with strength training, you can actually reduce the progression of this condition. So again, it's not just about allowing you to think better, but it actually changes your brain and potentially can slow down existing disease. And I also want to emphasize that we have shown that the benefits of exercise is not just reserved for those who are otherwise cognitively healthy, but also for individuals who already have some degree of cognitive impairment or those who have suffered a stroke. Now, we all know that exercise can improve our overall physical fitness, and this in part contributes to our physical resilience. Did you know evidence actually show that individuals who are more fit, physically fit, actually do better after experiencing a heart attack or a stroke as compared to someone who's less fit? So that's a prime example of resilience, okay? Now, I want to highlight exercise also prevents frailty, and frailty is literally defined by the lack of resilience. So as individuals age, we have these multi-system conditions. So often when we age, it's not just about one system that becomes impaired, multiple systems do. And what happens clinically is that we see individuals who express physical frailty, which is essentially hallmarked by weakness, unintentional weight loss, low physical activity, slowness, or usually very slow walking speed, and fatigue. And the burden of frailty is only going to increase in terms of our society as the population ages. And yet we know exercise directly prevents frailty. Exercise also prevents falls, which is the leading cause of injuries and costs 95% of all hip fractures among older adults. So a fall in itself is an adverse and traumatic event, and really actually robs individuals of their reserve and thereby making them less resilient. I also want to highlight that about a third of older adults admitted to long-term care following hospitalization for a fall. So again, about over a third of individuals who are hospitalized because of a fall will end up not being able to stay in their own homes and then have to be admitted to long-term care. And as well, individuals who are hospitalized because of a fall actually stay longer in the hospital as compared to any other reason for hospitalizations. So preventing falls is really critical. And really the good news is that exercise is the one single agent that's been shown consistently throughout multiple randomized controlled trials to prevent falls. And a specific program that includes balance and strength retraining can reduce your falls by upwards of 35%. And again, is not reserved for those individuals who are generally robust, but also this effect is persistent among individuals who've already had a fall. So I do direct a falls prevention clinic, and we've done studies to look at this very basic home-based exercise program that includes balance and balance and strength retraining across the spectrum of risk. So otherwise, independently community dwelling older adults to individuals who have frank physical frailty and have had on average 3 falls before they've been seen at the clinic. And across the spectrum of risk, this particular exercise program reduces falls by upwards of 35%. So we know a lot about the important role of exercise in terms of promoting both our cognitive and our physical resilience, but of course then we've got to get people moving. So getting people to move is actually quite a key challenge, because at the end of the day, it's really not our nature, right? We tend to gravitate more towards sedentary behavior, watch the TV, maybe have coffee with friends, and those are all good things, but at the end of the day, they are more sedentary behavior. So I just want to emphasize again, when we think about the dose that's really necessary potentially to promote health, it's really generally manageable. And what's really good is the fact that the evidence suggests that the more sedentary you are, the more you'll benefit from any increase in physical activity, okay? So the smallest dose could be a huge benefit. And again, just remember, perhaps just over 1 kilometer per day, so 2.5 times around the lap, or like a 14-minute walk, could potentially protect your brain. And the other piece that we know is that the more you move, the easier it gets. So when you exercise, in addition to the neurotrophic factor that gets released, endorphins get released. That's why we all feel better after we do exercise. I don't think any one of us regrets that we completed a physical activity bout, right? Has anyone ever thought, oh, I shouldn't have went on that walk, or I shouldn't have done a yoga class? We all feel better afterwards. We all feel very proud of ourselves and all these positive feelings. It's because of endorphins. And then when you exercise, you also release dopamine, which allows you to also feel more motivated to do things. So it's really a cyclic, sort of pattern of behavior. So as an example, we recently completed a trial where we asked older adults to come in 4 times per week, okay? Exercising each time an hour. So 4 hours dedicated to our research program. Recruitment was hard, not gonna lie, but we did manage to recruit 228 individuals, and the overall adherence over 6 months was about 80%. And at completion, we had a huge demand of, you gotta keep this going. And so in the end, we ended up sort of providing these free classes 4 times per week, and people can drop in. But just to say, it is a behavior that we can, shape our brain. So your brain literally will change as you exercise, and the next bout is going to be easier and easier. You just have to start. And if you do still have a hard time, think about developing SMART goals. So SMART stands for specific, measurable, attainable, relevant, and time-bound. And I'm just going to give a very basic example, such that I will do 10 sit-to-stands every day. So that basically means I'm going to grab a chair, I'm going to sit down, stand up, and repeat 10 times. You can try it. It's actually an exercise. And try it without your armrest. And it's one of the functions that many older adults actually lose over time. Measurable is that you can obviously quantify each day, and attainable, make it easy for yourself. So if this is your goal, put a chair in your bedroom, right? So the minute you get up, you can do it. Relevant, that it has to be a personal goal that is of meaning to you. So it could be that I really just want to be able to get out of the chair without using the armrest, or the fact that eventually this will allow me to take a bubble bath that I haven't taken for hours because I'm too scared to get in and out of the bathtub. And then time bound is that I'm going to do this for 2 weeks, and then I'm going to reassess, and maybe next time I'll put it up to 15 repetitions. But the more specific you are with your goals, the more that you will adhere and achieve them. And then lastly, I just wanted to say, maybe reframe your thinking. So if you really think you're so busy that you can't take out 30 minutes of your day to engage in a walk or go to a yoga class or something, then think about, I'm just going to reframe my sitting and lying down to 23.5 hours. Okay? All right? And so with that, I hope I motivated some of you to think about moving a little bit more. Thank you.
Okay, so that's the end of our formal talks. Thank you so much, Teresa. Thank you to all of our speakers for sharing such insightful and inspiring presentations. So we're going to open the floor to questions, and there are just a couple of rules. Put your hand up, and one of our lovely trainees and volunteers in the room will bring a microphone. And so wait for that, and once you have the microphone, we'll point to you to ask your question. We have 30 minutes, and that sounds like a lot of time, as you just heard, 30 minutes of exercise. No, but what it means is we've got like over 200 people here, so please keep your questions concise. But we'd love, I'm sure we'd love if you shared some of your stories afterwards. We'll have a reception in the back, and some of our speakers will stay and you can talk to them. So maybe just keep it to a concise question if you could. We'll get started now. Just raise your hand. Do we have the students? Are the students here? Right. Yeah, we need a microphone over here. I think they're trying to get it going. Comments over there.
Hi, thank you so much for the talks tonight. They were wonderful. I just wanted to say something really quickly is that I work in the clinical sphere, so I work in the emergency department, and I wanted to agree with you, Teresa, that we see patients that fall and they don't go home often. So it is really important to prevent falls, and actually the risk of death within a year after a hip fracture is about 22% at this time. So I think it's a really important goal. My question tonight, though, is what do you think about the role of prevention of glucose control, and like keeping glucose in control and preventing diabetes in the role of preventing, dementia, and the fact that recently there's been studies that show that GLP medications actually do help decrease the risk of dementia and the rate of developing dementia. So things like Ozempic or Mounjaro, those things.
That sounds like a Silke question.
Right. So yes, thank you very much. I think prevention is incredibly important, and that's where I think we are shifting substantially. Hopefully, the healthcare system is going to catch up now with the GLP-1 agonists. So we're seeing benefits that across numerous conditions like weight management, diabetes, but then also secondary conditions like, for example, dementia. It's being studied in Parkinson's but hasn't quite panned out yet. Addiction medicine is looking at this. So I am not paid by any of these companies, just to say this, but what this comes down to, I think, is this concept of prevention. We are finally getting to a point where hopefully not just being reactive in our healthcare system, which really is in many cases a sick care system. We react when somebody comes to the emergency room and has fractured their hip already, but hopefully we're moving towards prevention, and that can certainly play a big role. So controlling sugars to then prevent diabetes, or if you have diabetes, managing this well, controlling hypertension, controlling dyslipidemia, so high cholesterol, etc. All of these things are important to then prevent all these knock-on effects, such as strokes, such as heart attacks, such as dementia. And there's a medication that now works, but otherwise, which is way less expensive for us as a society, and I think much more enjoyable, and with many more other good benefits socially and etc. Are all these lifestyle interventions that empowers all of us to really make a difference to our own health individually and societally going forwards.
Thank you all for a very good talk, all with different facets, and it's kind of like a holistic view when you look at all of them. And I want to ask specifically Silke about, you talked about healthy eating and unhealthy eating, and I was wondering about not eating at all. So intermittent fasting, because a lot of the benefits you talked about is also related with intermittent fasting, and how would that relate to Parkinson's? What do you know about that?
Yes, so thank you, great question. So fasting certainly also has a lot of benefits, and there are different models of how this can be done and how long you eat and how long you fast, etc. There certainly are studies in several other health conditions that would support that. Specifically for Parkinson's, there aren't actually that many studies that I could tell you about. I think partially because with Parkinson's and with having to manage medication that you usually have to take every 3 to 4 hours throughout the waking day, and then maybe even overnight. There's so much in terms of interactions that it makes that a little bit more difficult to manage. So we don't have any good studies that would speak to fasting or intermittent fasting in Parkinson's. They're small studies, but I think it is a bit more difficult to implement. But not eating late at night and then having regular meal times is certainly important in Parkinson's as well.
I was struck and delighted by seeing all women on the panel, and notwithstanding what Dr. Boyd said about all brains being unique, I wondered if there was a gender factor in the brain and in how it manifests itself in the exercise or learning or eating dimension that you've spoken of.
So it's a fun question, and I wish I had a really good answer, but the honest truth is we haven't done enough work in women and females to really know if there's a very specific gender or sex-based difference. There are some suggestions in my work, especially in the brain stimulation area, neuromodulation, that at least sex, male versus female, may indeed matter. And that the female brain may be responding slightly differently depending on hormone level at that particular point in time to the brain stimulation itself. But it's a quite interesting question. We do see, for example, in the area of stroke that there are big differences in how males and females and women and men recover and respond. So women have a much poorer outcome after stroke. They have more severe strokes, they're less likely to be offered aggressive medical intervention, they're less likely to be recognized when they're having a stroke, because women have strokes at different times in their lives. We have strokes when we're pregnant, we go through menopause, and when we're very old. So 3 very distinct phases. Men will have strokes increasing as they get older. So you think of stroke as being kind of this old person's disease, but it's not true for women, and strokes are often missed when they happen earlier in life. So there are some important key differences, but it's a real goal of my research, and I'm going to guess that Silke and Teresa will echo this, to try to increase the volume of research that actually helps us understand those differences, again, in the goal of having more accurate interventions for specific populations. It falls right in line with that. And I don't know if either of you would like to add.
Yeah, I guess that I can't really comment on the gender piece, but when it comes to the effect of exercise on cognitive outcomes, it does actually, and again, in the older adult population, it actually seems females may benefit more than males. As to why, I don't know.
Yeah, just to add
just to add to this, we definitely need more research, there's no question. Women tend to eat better than men. They tend to eat a more healthy diet. That certainly came out in our own studies. And in our own study, the women's difference between age of onset, between the highest and lowest group of healthy eating, it was quite a bit higher for the women than for the men. So it seems that there might be potential for women to actually do better with those interventions, but definitely more research is needed. Yeah.
There's a question in the front.
Thank you all very much for this amazing information. And I think I have two questions. One is your thoughts on keto diet and its effects on keto or carnivore diet that's been promoted a lot, especially for brain health, whether it's on a long term or about every 3 months, every 6 months. And if it's useful or not. And my second question is related to the sex and to female. And I have been reading a lot about the higher percentage of females having dementia and Alzheimer's and dying from it, especially on the onset of perimenopause and going into menopause, and the differences in the effects of intermittent fasting, of exercise, and even with eating a good Mediterranean diet, we still go through I'm a nutritionist, and going through perimenopause, I feel like I'm going stupid, like brain fog, and haven't really had much help from clinical. Yeah, so your thoughts on that?
Teresa, did you study this a little bit?
Yeah, so perimenopause and brain health is definitely a kind of hot topic right now. So there's been some studies from US whereby they've shown that as females go through perimenopause, there's actually significant changes in the brain, including greater rates of atrophy of the hippocampus, as well as potentially a switch from like a ability to use glucose as the fuel versus kind of having to switch to more of a ketone approach. So just to say that it is now being recognized that it isn't just a phase we go through and that it could be in itself a critical window to intervene for female brain health. In regards to female being quote at greater risk, it really depends on the sort of the country you're looking at. In general, females do live longer, and so because of that, you will tend to have more females have dementia as compared with males just because of the longer lifespan. That said, it also may be related to how we diagnose. So there are some sex differences in cognitive abilities, and so in detecting deficits, females may require a more sensitive assessment to detect changes, early changes, as compared with males, especially when it comes to episodic memory. So there's actually known sex differences as to how we traject after diagnoses. So we tend to be diagnosed a little bit later, and then we also then to, after diagnoses, potentially decline faster. But again, it could be because we've been also diagnosed later as well because of the sensitivity of some of the testing.
So the late diagnosis only the late diagnosis is only because late testing, or why are we being?
No, it's just so there's standards in testing, but then if there's differences in how generally how males and females in terms of how we perform, right, then it might be more sensitive for one sex in terms of detection versus another. So we need to develop more sex-specific testing when it comes to the cognitive profiles. But that said, I think biology may relate to the fact that we do go through perimenopause and estrogen is very beneficial for the brain, or estrogen. There's different estrogens.
Yeah, so I completely agree with that. You know, I've gone through that myself, and I'm not letting anybody take away my estrogen, but there we go. But coming to the ketogenic diet, we just actually ran a study into the ketogenic diet in people with Parkinson's, but we paired it with the Mediterranean diet. to offset some of these difficulties of a very high animal fat intake, which indeed, if you take the classic ketogenic diet, there are studies actually even from Vancouver here, from the cardiologists to show that in the long run, you'd actually really increase your risk for cardiovascular events. So important to do this with healthy fats, and the other thing we did, we compared this to a Mediterranean diet with medium chain triglyceride supplementation. I see people in the audience who are kind enough to actually participate in the study, because if it wasn't for the people who are participating, then I wouldn't have anything to tell you. And so the outcome was that this was a feasibility and safety study. We want to look at the microbiome, but the feasibility piece, and we had interviews with the participants afterwards, was that the ketogenic diet is really difficult to sustain. It is difficult in social contexts because everybody else is eating something different. It is difficult in the long term, and in Parkinson's, which is of course the field I know best, the studies that have been done into the ketogenic diet are actually all fairly short term, so nothing more than 12 weeks, and relatively small. Whether there is a benefit for symptoms is mixed between those different studies. We saw maybe like a 1 point on a scale that is, a total of 120 points. So a fairly small difference in favor of the group that had the Mediterranean diet and the medium chain triglyceride supplementation. Yeah, but there wasn't a mind-blowing difference even in the ketogenic under the ketogenic diet and the kind of functional outcomes. Having said that, for other conditions, I'm talking specifically Parkinson's disease, diabetes, etc., this might be different. It's not my area of expertise, of course. So I think it was worth investigating, but I would say that, if I had to do this again and what we've learned, I would probably go for ketone ester supplementation rather than doing a whole ketogenic diet, because the potential benefits in the brain are improved energy utilization, because what happens is that the brain cells that are aging are not able to use the glucose, the sugars that we usually use as the main energy source, but these ketone bodies can be used, and they can kind of rescue, that is the thought, there's some imaging evidence for that, can rescue the ability of these cells that are already compromised to actually utilize energy from these ketone esters and ketone bodies then. Yeah, and that keeps those cells going for longer. There are other effects as well, but so generally speaking, you got to be careful. Do it really under physician guidance or dietitian guidance. Be aware of too much animal fat and potential negative effects in the long run from that, and it is pretty difficult to sustain. And the thing for our population, so people living with Parkinson's disease, I would supplement it probably going forwards if we do a study again.
Hi, my question is, can lower levels of mental stress, such as similar to having low levels of physical stress in forms of exercise, be helpful for brain health, or are all levels of stress harmful?
So no, so you can have positive stress, of course, as well. You can have negative stress. But if you look at stress reduction, so for example, with mindfulness or with mind-body practices, or there are certain yoga practices, Tai Chi, etc., but particularly mindfulness and meditation, you can actually reduce the level of cortisols, which is a measure or a marker that we use for the activation of the stress axis in the body. And you can reduce the level of inflammation, so you can measure cytokines that would usually drive inflammation. You can reduce those with mindfulness. So very measurable outcomes, and you can actually, coming back to the title of our evening here, you can change the structure and functional connectivity of the brain as well if you're practicing long enough. So mindfulness for stress reduction is highly recommended. We know that stress is a risk factor for brain conditions such as, for example, Parkinson's disease, dementia, etc. So really worth doing.
I'm going to just jump in with a question that I guess we could debate for quite a long time, but this is for Lara. given how much we rely on digital devices, and this is increasing in the seniors population as well, do you think technology is helping or hindering our ability to learn and adapt? I mean, obviously your app is an exception, but...
With the exception of Teresa's app. So I don't think it's doing anything. It's just changing how we learn, right? We learn, but just recognize that if you're on a device, you're learning on a device, and you're not learning, in other capacities. And your learning may or may not generalize to other environments and capacities. So learning is very environmentally specific. So really good evidence of this. For example, studies have been done in people with severe depression, and they're very unable to think of happy events, but they can conjure or recall many negative events as this context-specific memory. And so this is kind of the concern that I have around devices, and I have young adult children who walk around like this all the time, that their reliance is now entirely, their learning is all entirely within that digital device and in that digital interaction. One of the other things I would just mention about being constantly in your technology, it comes back to a brain health concept. And so our brains are actually never silent. Our brains are always active. And when you're resting and seemingly doing nothing, when you have one of those moments where you drift off, and if you're honest, all of you did that a couple times tonight, right? All of a sudden you're like, I'm not on task. Our brain is going to a state called resting state, or it's called the default mode network. It's a very stereotypic network. You can even see it in young infants if you put them in MRI. And there are many in the field who now think that this kind of jumping off topic, going to default mode network, is actually really important for brain health. It's a brain reset. There's a colleague of ours at UBC who is studying the idea that this is when spontaneous creativity happens, when you're seemingly off topic and you have that kind of aha moment. So there's a concern, if you never let yourself be off topic, if you never let your mind drift, because every time you have a free moment, you're engaged with the device, actually it might be very unhealthy for your brain in the long term. Our brains actually need to go to default mode network. And so it's just another kind of thing we don't yet understand, but is a potential concern for always being engaged with your device. I very bravely left mine in the green room. Look kind of naked. I know, but look, Silke has hers.
I use it wisely.
All right. Maybe one last question, and then we'll take a break, and you can ask questions more informally. Go ahead.
Hi, this is a question for Dr. Lara. I have a question about the strokes, and has there been any research in the psychological or emotional department that contributes to individual therapy?
Yeah, it's a really interesting and important question. So the bulk of research in terms of emotion after stroke has really looked at the role of depression in stroke recovery. And depression in stroke and in really any condition, including in a seemingly healthy brain, significantly disrupts your capacity for learning. It reduces the availability of neurotransmitters that are beneficial for that. And so we know that many individuals suffer depression after stroke. It's a very natural consequence of a severe life event. This can be really a hindrance to the brain's capacity for repair and for healing. And so there are a number of interventions being investigated. And in fact, this winter, we have a network across Canada called CanSTEM, where we participate together in these brain stimulation studies. And so we'll actually be starting a study this winter. We're actually be looking at the effect of brain stimulation for depression in people with acute stroke, with the hope that if we can better remediate and help people with their depression, we'll see even greater amounts of recovery in those patients. And so that speaks to kind of this importance around it. It also extends to families as well. It's a really severe and difficult event with really any of these things, a fall, Parkinson's. And so that can actually reduce the whole capacity of the of the family unit of the community to help people recover. So it's a really critical consideration. So I would also put one last plug in that one of the most effective interventions for depression is exercise. Even though it's incredibly hard, it's not a drug. We understand its action and mechanism in the brain. It's long-lasting and effective, and it's cheap. And I didn't know, but it only takes 14 minutes. I start using that with all of my patients. It's another easier way to address that problem.
Okay, so with that, I'd like to thank everyone for your thoughtful questions. Special thanks again to our three speakers, Dr. Lara Boyd, Dr. Silke Appel-Cresswell, and Dr. Teresa Liu-Ambrose for sharing their insights and perspectives. Let's give them all a hand once more. So I think tonight has shown us just how adaptable and resilient the brain is, and how learning, exercise, nutrition, lifestyle choices can shape its health across the lifespan. At the Javad Center for Brain Health, this is what drives our work every day. And as scientists, clinicians, staff, trainees, we work together to find treatments and cures for brain diseases and help people live healthier lives. But progress doesn't happen in isolation. It's made possible through partnerships, community support, and people like you who believe in the power of research to change lives. If you're inspired by what you heard tonight, I invite you to stay connected with us. You can follow us on social media. You can scan this QR code on the screen, pick up a postcard to learn more about our program. I think they're out in the lobby there. And please consider participating in research studies or donating to support research efforts so we can continue to advance discoveries in brain health and wellness. So now please join us in the lobby for a reception with light snacks and refreshments to continue the conversation. We also have a few of our trainees stationed at the training needs graduate student, maybe a postdoc will be out there. We also have a few of them stationed at several tables, and they can be identified with bright blue lanyards. They were passing around a microphone. They'll be happy to share their research and answer some of your questions. So thank you again for being here tonight and for taking an active interest. And keeping our brains strong and healthy. We look forward to seeing you again. And if you've heard that, have a wonderful evening.